Hello and welcome to the Power Tools for Coalitions webinar series. I'm Kinkini Banerjee, the Senior Coalition Relations Manager at USBC, and I'm so glad to have you join us for this session. The Power Tools series is organized as part of the USBC's training, technical assistance, and capacity building support for our network of state, territorial, tribal, and community breastfeeding coalitions across the US. As you know, the access is free and open to anyone interested in forming or leading coalitions or any other entity in the breastfeeding field. So breastfeeding advocates, coalition leaders, members are welcome to join us, and the webinar announcement emails are sent through the USBC's coalition announcement list. We host 4 different series, and this series is the Power Tools series occurs on the 3rd Wednesday of odd-numbered months from 2 to 3:30 p.m. Eastern. And all the details, registration slides, and handouts can be found in the Power Tools page on our website. So you can go to www.usbreastfeeding.org/power-tools, and the session details are also posted in the Coalition's Learning Connection. So if you aren't already a member of our Learning Connection, it just takes a second to sign up, and you can go to www.usbreastfeeding.org/CLC. So to streamline access, these series have now been set up as auto registration. So once you register for the series, you are set, and 2 weeks before the series, the next session, you will get a reminder email. You'll get follow-up emails. So this is a great way for you to know what's happening in each of our series. We know that this is in the middle of a work day and not everybody will be able to attend a live session. So this series registrations will send you the auto reminders and also information about where you can find the archives and where you can download the handouts and other ancillary materials. So to find archives of past sessions, again, it's on the Power Tools page on our website. And if you go to our website, www.usbreastfeeding.org, you'll see that the last tab is the one for coalitions. Click on that and you'll see, the CDC, USBC, bi-monthly webinars, the Power Tools, and the others. So click on the Power Tools webinar and it should open up the page that'll take you to the materials. So we have a large number of attendees today, and all attendees are in listen-only mode, but we do encourage you to send questions, and so as they come up for you, so type them up in the question box, and this is how you do it. You should see a control panel on the right of your screen. In case you don't see it, it might be minimized, so just click on that orange tab with the white arrow and it'll pop back out, and scroll down your control panel, and just under the audio tab is the question tab. If you click on that, it opens up a text box and you can type it in. We will have our presentation at the first half of the session, and then we have about 20 to 30 minutes for Q&A at the end of the presentation. If you have any audio or other tech problems during this session, please send an email to coalitions@usbreastfeeding.org and our staff will be able to help you. And that brings me to today's topic, using mPINC as a tool for improvement. Nearly all births in the United States occur in hospital settings. Maternity care policies and practices significantly impact whether a woman chooses to start breastfeeding and how long she continues. The Surgeon General's call to action to support breastfeeding, the IOM report accelerating progress in obesity prevention, the National Prevention Strategy, as well as the objectives of the Healthy People 2020, each call for the implementation of maternity care practices that are fully supportive of breastfeeding. CDC collects data every 2 years on maternity care practices and policies related to infant feeding through a national survey known as the Maternity Practices in Infant Nutrition and Care, or mPINC. This survey is sent to all registered birthing facilities in the U.S. and territories. So in 2007 was the first time the mPINC was done, and it established a baseline measure of these practices and documented the extent to which practices vary by state. And now these biannual data from the survey provide state with summarized responses from all their facilities, and then each facility also gets subscores across 7 maternity care practice domains. So in today's session, we will hear the highlights from the latest, the 2015 mPINC survey, and we will also learn how state health departments and breastfeeding coalitions can use the mPINC data to facilitate their work with hospitals and birth centers in improving breastfeeding care. And I'm delighted to introduce today's presenter, Dr. Jennifer Nelson. Dr. Nelson works as a medical epidemiologist in the nutrition branch at the CDC. Her work on the infant feeding team focuses on improving national breastfeeding rates and breastfeeding-related maternity care practices. She received her MD from Morehouse School of Medicine and completed her pediatrics residency at Emory University. In addition, Dr. Nelson has a master's in public health from Emory University, and prior to going to med school, she worked as an epidemiologist at CDC in the foodborne diarrheal disease branch on national surveillance of foodborne diseases with antimicrobial resistant enteric diseases. So we are very, very thrilled to have Dr. Nelson with us. Welcome, Jennifer, and we are so glad to have you present today.
Thank you very much. Give me 1 second. Okay. Good afternoon, everyone, and Happy New Year. I do want to thank USBC for inviting me to do this presentation. I think my personal bias is that mPINC is just a phenomenal tool and a phenomenal resource, and I feel very grateful to be able to work at CDC on this wonderful survey. So the goal of today's webinar really is to report on the 2015 mPINC data, which is our most recent survey, including some of the trends since 2007. But I also want to take time to highlight how different states, hospitals, and other stakeholders are using their mPINC data in order to improve maternity care practices within their domain. And, you know, as the beginning of the new year, I think this is a great time for us all to think about, you know, kind of how we can use the mPINC as a tool, and, you know, what improvements we might be able to make. So as we're going through this, think about your realm of domain and how you might want to make those changes, and maybe set a New Year's resolution related to mPINC. So many people are using the data to make improvements in maternity care practices, but I only have a time to discuss a few handful of examples. I also wanted to note that I tried to intertwine the 2015 and the trends data with examples that people are using mPINC in order to make this a more interesting presentation. In many of the examples, there's a direct correlation between the project that I mentioned and with the improved mPINC scores, whereas in others, there's not a direct correlation. So just keep that in mind as we're going through the slides. So most of you on the call are probably familiar with the methodology of mPINC, but I did want to go quickly through it in case there are new people on the call that aren't very familiar with mPINC. So as Kenny mentioned, mPINC was launched in 2007, and we administer the survey every 2 years. The unique thing about mPINC is that it's a census of all hospitals and birth centers, meaning that any facility that has that had a birth in the previous year is eligible to participate in the survey. And we ask about breastfeeding-related maternity care practices and policies. And when we call the hospitals, we call the hospital switchboard. We have a very standard protocol for how we call the hospitals. We call the switchboard, asking for the mother-baby manager or the labor the manager, and then once we get that person on the phone, we say, who's the best person in the hospital to answer these questions? So we get the information from a key informant, but we encourage that key informant to ask other people if they're not familiar with the answer and so forth, in order to get the best data available. And the great thing about the mPINC survey is that in all 5 cycles, we've had greater than 80% response rate, which really is unheard of. Most surveys, don't have a very high response rate at all. In fact, surveys of physicians, the response rate's typically around 30 or something. So, and I think in part, one of the reasons why our response rate is so high is that we do provide the benchmark report, which is a hospital-specific report, back to the facility, in which we give them their total mPINC score and then the scores of the 7 subdomains. So I think that that's one of the true benefits of this survey, is that, not only are we collecting information from hospitals, but we're also giving back to them. So now to talk a little bit about some of the trends that we've seen, for instance, from 2007 to 2015. So this is the average total mPINC score for all 5 surveys. And as you can see, that in 2007, the total mPINC score was 63, which has increased to 79 each year. We've seen it increase. And in 2015, the total score was 79, which is an increase of 16 points. I want to take a little time to go over this figure, since I will be presenting this map for both the total mPINC score, but as well for each of the subdomains that we score. And so the states and territories, which hereafter I'll just call states, with total scores of greater than 90 are in the darkest color, followed by states scoring 80 to 89, then states scoring 70 to 79, and then states scoring less than 70 are in white. Again, with the 2015 national average was 79, with a range from 60 to 96. And we had 3 states, Delaware, New Hampshire, and Rhode Island, that have scores above 90%, above 90. So, So here's an example of a question that you might have heard. Hospitals in our states have many barriers implementing evidence-based maternity care, including resistant doctors, formula supplementations, skin-to-skin care in the operating room, just to name a few. How can we improve our overall mPINC score? So in order to answer this question, I'm going to give you an example from Hospital A, which is a safety net hospital that serves a medically underserved population. 25 to 35% of the patients are uninsured, 40 to 60% are underinsured, and the average annual income of the patients is less than $15,000. A majority of the patients are Hispanic and Spanish speaking, and most are new parents, they're new moms. Additional risk factors for patients in this hospital that this hospital serves is that 57% have received either minimal or no maternity care, and many of the pregnancies are complicated by factors such as poverty, obesity, diabetes, and hypertension. So a pretty tough population to care for, in that they have a lot of constraining factors on they don't get the prenatal breastfeeding education, and might come in last minute, and so a really challenging situation. Further challenges that this hospital faced are that they are in a very remote location, which makes acquiring physician and nurse resources a bit of a challenge. And then also they had noticed a decline in births, which was attributed to depressed local economy, violence in the area, as well as competition from other healthcare facilities. Yet despite all of these challenges, they were able to increase their total mPINC score from 65 in 2011 to 92 in 2013, so over a 2-year period. But you may ask, how in the world did they do this? So this effort was led by a group of maternal child nurse managers, and they really went out of their way to seek and acquire knowledge not only related to the Baby Friendly Hospital Initiative, but also to the mPINC survey and understanding the mPINC survey and what we were questioning. They they joined lactation organizations, and this enabled them to be introduced to new ideas and new information from other people, how to solve problems and so forth. They utilized the baby-friendly guidelines, guidelines and evaluation criteria, as well as the mPINC survey to guide their improvement work by serving as an external benchmark in defining their data collection processes, which we'll talk about in a little bit. They also, they did this in the context of a Plan, Do, Study, Act, or PDSA model, which makes incremental changes. And so there's 4 phases to the PDSA model, and each phase, once you pass through each phase, you move to the next one. And so it really helps, it's very incremental, and so you're not overwhelmed at once, and you just slowly go through the process. So I want to talk about a few selected challenges that this hospital faced. You know, many hospitals out there do face challenges, especially when they're trying to improve maternity care practices. I thought it was great how they identified the problems and then how they addressed them. So first, they had to the initial training was of 443 individuals, and they verified over 5,000 hours of training. But like many hospitals, they were a teaching hospital, which means they had a constant influx annually of 90 to 100 new residents and faculty that they had to, train. And so they established a process for the ongoing training and education. And then I think one of the great things that they did was they developed their own experts, which meant they went beyond the required training, 20-hour minimum of training. So I think that that's important, in that, they didn't rely on other people to be experts, but they really brought it in-house, and they said, we're going to receive extra training so we can have our own experts. Second, they worked to address their newborn hypoglycemia protocol, which I know is a very common issue in hospitals. How do you address hypoglycemia? When they started the process, every single newborn that was born was tested for hypoglycemia. And so they sat down with their pediatric team and worked out a plan that everybody was happy with. And so what they did is they developed a protocol where only those at-risk infants or symptomatic newborns were screened for hypoglycemia. And that resulted in a reduction of 46% of newborns that were not tested because they really didn't need to be tested. And so, I think that that's a huge success. You're really, you're saving the pain of a needle stick for the newborn, and then, lab results and so forth. So I think that's a huge win. Third, they had a large Hispanic population, which they needed to address the culture of low dose, which is the belief that formula and breastfeeding together, that you get the healthy aspects of breast milk while you get the vitamins from the formula. And so the way that they did this is they really focused their efforts on nurse education, as well as developing a maternal choice form. And then after that step, they went and they implemented a chart review to ensure that if formula was a medical necessity, that there was a documentation for why it was a medical necessity. And then finally, they also linked formula distribution through the Pyxis, and so individual staff members would have to sign out the formula, and so they could track who was selecting formula. And so if there was one particular individual that had a tendency to give new moms formula even though they didn't need it, then they could go and talk to that one person and not not make it an issue for the whole staff. So I think that being able to have that focus and address problems specifically where they are was really neat. Okay, so what are their results? As a result of these interventions and efforts, their vaginal deliveries, 97% had skin-to-skin contact, 92% received breast milk as their first feed, 95% of mother-infant dyads were transferred as a couplet, and then their stable C-sections had similar results. And I think most impressively is that their exclusive breastfeeding rates increased from 16% in 2012 to 42% in 2015. And then again, they demonstrated an overall increase in their total mPINC score from 65 in 2011 until 92 in 2013. You might wonder why I'm not talking about their 2015 mPINC score, and that's because the data that I just presented are from a published study, and so the study went through 2013. So what did they attribute some of their success to? So first is that the process was driven by nurse leaders that had the authority, the motivation, and the resources in order to move practice forward. And I think that that's so critical. Not only did the nurse leaders have the vision, but they also had the ability to implement that vision. And the other thing that they noticed is that they had 3 nurses pass the IBCLC exam, and they commented on the fact that it really sent a message of this to the other members of the nursing staff, that this is serious. We're taking this very seriously, and we're going to make these changes. And I think the other thing too that it really does is it increases the capacity of your IBCLCs and your experts in lactation on the floor. And so there's more, if there are more experts around, if somebody has a question, there are more people to go to and to answer that question. And as an epidemiologist, of course, I have to talk about data collection. So they developed a system where the data was abstracted on a daily basis by each of the unit leaders, and they had actually developed a customized form that captured the baby-friendly hospital elements as well as elements from the mPINC survey. And so I think that this is important for several reasons. First of all, they put the impetus on the unit, and so each unit is engaged in the process, and that unit was responsible for their data entry, they were responsible for the abstraction data, and so they can identify areas within their unit that they need to improve, and that they have the sphere of control over that unit, so they are able to make those improvements. But then, with the review of the data, they reviewed it daily and then monthly, and I think that keeps their the goals and the status of those goals in the forefront. And I think about being the new year. You think about your New Year's resolution. You're more likely to maintain progress towards whatever resolution that you set if you think about it constantly, and if you assess how you're doing and how well did I go to the gym 3 times this week or did I go 5, and I think that the longer that you think about that and the more focus you have on it, the more likely you are to continue, and then it becomes a habit, and then you actually achieve your goal. And then also they stated that their data collection process actually helped as a tool to improve patient handoffs between labor and delivery in the postpartum unit. And that is just critical for safety measures. And there is a lot right now in the medical literature about patient handoff, especially among resident physicians and physicians. And so I think any mechanism to improve patient handoff is great. So I'm sure you're wondering who Hospital A is, and it's the University Medical Center in El Paso. And like I said, they published this experience in the Journal of Nursing for Women's Health. And again, I would strongly encourage you to go and pull this article and read it. I think it shows how hospitals identify the barriers and how that they address those barriers. And just one little quote from the article, the mPINC survey provided external benchmarks used to guide the transformation of our maternity care and to define our data collection processes. So again, I also think that it highlights that how important mPINC was for this process. And so kudos to them. So next, so that was, you know, the total score. Next, we'll talk about the mPINC subscores. So looking at labor and delivery care domain, the score has increased from 59 in 2007 to 85 in 2015. Again, that's an increase of 26 points. So here's the state map with the state-specific labor and delivery care scores. Again, the darker colors indicate better scores down through white, which indicates a score of less than 70. The national subscore was 85 with a range of 65 to 98. So there are several states that are doing very well in this area. So to highlight the labor and delivery subscore, I want to focus on Iowa and how they used their data not only to improve their labor and delivery subscore from 50 in 2007 to 85 in 2015, but this also improved their total score from 61 to 75. So they have made significant improvements in skin-to-skin care after cesarean birth, as well as in the component of the subscore in that routine procedures are performed skin-to-skin. So a few years ago, the Iowa Department of Public Health realized that they ranked 31 out of 53 states on the mPINC survey, and this really prompted them to take a deeper look at, you know, kind of what was going on with their maternity care practices. And Iowa, obviously being a very rural state, 89% of their counties are rural, and so they recognize that that might be a barrier, as well as they had a really high proportion of Medicaid births. About 40 to 60% of their births are Medicaid. And so in noting that these hospitals are, you know, in rural areas, they really didn't have the resources to improve breastfeeding education for their maternity care staff or to provide the technical assistance. And so what they did is they developed a plan that specifically targeted the rural hospitals. They met with key stakeholders in those hospitals, including OB managers, the chief nursing officers, and the health educators. And in doing that, they reviewed the hospital's breastfeeding policies as well as their hospital-specific mPINC results. And then they also developed a training course that was titled 6 Steps for Success. They've continued this project in recent years, but it's shifted a little bit in that they focus on 4 to 5 rural hospitals with a large portion of Medicaid births. So that was the original criteria, but the additional criteria is that now the hospitals have to have an mPINC score which is less than the state average. So here the Iowa Department of Health again works with a hospital to review their hospital-specific mPINC results and to determine opportunities for improvement and developing an improvement plan with at least 2 dimensions of care. And so, you know, I think that this highlights an example of you know, the barriers and challenges in Iowa are very different, say, than, you know, a more populous state. And so it really is taking a look at your specific situation and trying to identify, you know, how to address that specific barrier. Okay, now the next subdomain is feeding of breastfed infants. You'll again see that the scores increased from 76 in 2007 to 86 in 2015, which is an increase of 10 points. So here's the map for feeding of breastfed infants. Most states are doing relatively well in this area, with a 2015 national average of 87, ranging from 68 to 97. Okay, and so feeding of breastfed infants, this subdomain score includes initiation of breastfeeding after birth and in-hospital supplementation. And in order to highlight this domain, I wanted to focus on what California has done with their mPINC data, in that they produce both county and region-specific mPINC reports, which are very similar to the state reports that CDC produces. Additionally, California actually links their mPINC data to data collected by their state newborn screen program, which is the which collects information on infant feeding from birth until the time of specimen collection, which is usually done at 24 to 48 hours. And the great thing about this linkage is that it actually enables them to have hospital-specific breastfeeding rates, which includes both breastfeeding initiation and exclusive breastfeeding. And you know, if you have the ability to do that in your state, or to encourage your state health departments to do that, that is just a huge, it's really powerful, because you know, to be able to link, you know, have actual outcome data, the breastfeeding data, the exclusive breastfeeding data, especially on a hospital-specific level, is something that we're missing at the national level. So most of you are probably familiar with the California project, because USBC has one of these webinars was actually presented by the Department of Health, and so you can find that on YouTube. All right, next is breastfeeding assistance. So in this domain, there was also an increase from 79 in 2007 to 89 in 2015, which is a 10-point increase. So in looking at the state-specific sub-scores for this, there's a no white, so that's great. This is one area where all the states and territories have scored above 90, which is just phenomenal. The 2015 average is 89, with a range of 80 to 100. So in order to illustrate breastfeeding assistance, I want to use Massachusetts as an example. So Massachusetts has improved their breastfeeding assistance subscore from 86 in 2007 to 95 in 2015. And this include marked improvements in the use of the standard assessment tool, as well as limiting pacifier use. So this report that the Bartik et al. Article is from the Massachusetts Baby Friendly Collaborative, and so I realized that the changes in Massachusetts reflect improvements from many, many more facilities than just the 4 facilities that participated in this collaborative. But I really encourage you to pull this article, because it is a phenomenal resource of, you know, barriers that these hospitals faced and how they overcame those barriers. So it's really a super paper. So the goal of the Massachusetts Breastfeeding Baby Friendly Collaborative was to assist hospitals in achieving the 10 steps by sharing information, ideas, support, and encouragement. And so in the article, they actually summarized the recommendations that the collaborative made, as well as actions that were taken during the process. And of the things that they specifically discuss are using existing tools to make small steps that really count. So for example, they mentioned the latch assessment tool, as well as keeping pacifiers in the locked medication system. And I was actually on a call yesterday with the Indiana Perinatal Network, and they had also mentioned that some hospitals are putting the pacifiers in the gift shop. So then it really takes it takes the nursing staff out of the decision of whether mom gets a pacifier or not. So the family actually has to go down to the gift shop to buy the pacifier, and I thought that was a great solution. So I want to read this quote from the paper because I think it highlights a couple of things. It says, the mPINC survey offers an important opportunity for gathering internal stakeholders to complete the survey together and discuss what practices could be improved, as well as brainstorm ways to change those practices in terms of attaining specific score gains for change practice. It can serve as the missing catalyst to unite staff to improve performance on a specific goal tied to 1 or 2 questions on the mPINC survey. So the reason I like this quote, from the article is that first it highlights teamwork. It says, you know, I've bolded the part where it says complete the survey together. And I think that that's really truly how you're going to get the most accurate results for a facility, is to really work together. You know, if you're not sure about a question, or, you know, then go and seek the person that has the best information. And truly, I mean, we collect the data on the national level, and that's important, but also giving the benchmark reports back to the hospital, that is, you know, helps them identify where they need to make progress. And so the better data that they have, the better data they give us, the better data they have to know, you know, where change needs to be made. And I think, you know, teamwork really, by completing the survey together, it facilitates discussion on, hey, you know, this is going really well, but this maybe not be going so well. And it really, I think, raises the attention to certain areas. So, you know, teamwork is important, especially when you're trying to make systematic changes, you know, in maternity care, and probably some changes that have been going on for years, if not decades, which can often be hard to change. So the more people are on board, the more people that can be encouraging and supportive of the change process. The second great thing that I love about this quote is that it really focuses on a specific goal tied to one or two questions. And, you know, we all think about our, you know, New Year's resolutions that, you know, since it's January. And so, for example, if somebody has a New Year's resolution to lose weight, and, you know, it's January the 1st, I'm going to lose 10 pounds and, you know, X number of months. Well, if you go about it and say, okay, I'm going to cut 500 calories out of my diet. I'm no longer drinking any, you know, sugar sweetened beverages. I'm going to increase my fruit and vegetable intake. I'm not going to eat any desserts. I'm going to exercise an hour a day. I'm going to stop watching TV. I'm going to get 8 hours of sleep. You know, that's a lot of behavior to change all at once. And so, you know, you might do great for a week. The second week might be a little harder. The exercise doesn't happen on a daily basis. And then, you know, soon you're back to your normal routines because you haven't really changed behavior. So when we actually counsel people for obesity prevention, we just say start with one small goal. What can work for you? Start with a baby step. Maybe it's I'm going to start by cutting down my Coke consumption from 3 Cokes a day to 1 Coke a day. And then once, you know, you've been able to do that for 2 weeks, so you've made success, and that success is, you know, you can feel that, wow, I really did something. And so you move on to the next step. Maybe it's, okay, now I'm going to cut out Coke, you know, maybe 1 Coke a week or something. And I'm not picking on Coke, sorry, sugar sweetened beverages. I'm from Georgia, and so I drink Coke and sweet tea, but no, I'm not trying to pick on Coke in particular. And so once you've experienced that success, you're more likely to move forward and make behavior changes in small increments. And so by identifying 1 or 2 specific things you can focus on, I think hospitals are more likely to accomplish their goal. All right, moving on to the mother-infant contact. Again, there's been significant improvements in this subscore from 67 in 2007 to 83 in 2015, which is an improvement of 16 points. Here you can see a majority of states scored above 80, with a national average of 83 and scores ranging from 62 to 96. Okay, since mother-infant contact includes rooming in, I like to focus the efforts made within Puerto Rico. These data were presented at an abstract in 2015 at the AAP, or the American Academy of Pediatrics meeting up in Washington. And so Puerto Rico had noticed that less than 30% of its hospitals participated in the 2009 mPINC survey. And as such, the Breastfeeding Coalition of Puerto Rico Department of Health, along with AAP, WIC, and Healthy Start, initiated efforts to improve their mPINC participation and to improve their maternity care practices. Their first Mother-Baby Summit was attended by 67% of hospitals providing maternity care on the island. And so as part of the process, they did an initial assessment with a follow-up survey at 12 months. And as you can see, they improved their mPINC participation, as well as saw great improvements in the proportion of hospitals with breastfeeding policies and the proportion that offered rooming in for the mother-infant dyad. Puerto Rico continues to improve their mPINC participation, with 53% of eligible facilities participating in 2015. Their mother-infant contact subscore for Puerto Rico improved from 61 in 2007 to 65 in 2015. Okay, next is discharge care. There have been substantial improvements in the subscore from 40 in 2007 to 68 in 2015, which is an improvement of 28 points. However, you can see from the state map that there's still much room for improvement. The two main components of hospital discharge care subscore are staff provision of appropriate discharge planning, which includes referrals and other multimodal support, as well as distribution of hospital discharge packs containing infant formula samples and marketing products. To update the information, you might have seen our 2015 pediatrics articles. Hospitals are continuing on the trend of not distributing hospital discharge packs containing infant formula and formula marketing materials. Since the inception of mPINC, there's been a decline of 51 percentage points in the number of hospitals providing discharge packs, and this is really a great success. There's 7 states and territories that have no hospitals that distribute discharge packs, including the District of Columbia, Delaware, Massachusetts, New Hampshire, New York, Rhode Island, and Vermont. And Maryland has also discontinued discharge packs, but when these data were collected, one of the hospitals still indicated that they were distributing packs. And then there are 40 states that still have greater than 25% of hospitals distributing discharge packs, including 17 with 25 to 49% of hospitals, 2 states with 50 to 74% of hospitals, and 1 state with greater than 75% of hospitals. So since the hospital discharge domain also includes appropriate discharge planning, I wanted to mention a report by Perez Escamilla et al. And the report is titled The Impact of Baby-Friendly Hospital Initiative on Breastfeeding and Child Health Outcomes, a Systematic Review. This report was published in Maternal Child Nutrition in February of 2016. And basically it showed that community support, or Step 10, was really essential in sustaining any breastfeeding impacts that occurred during the hospital, as part of the Baby-Friendly Hospital Initiative. And so, in the United States, we do really well with initiation. Our initiation rates are 81%, but our breastfeeding duration rates really drop off. Any breastfeeding at 6 months is 51%, whereas our exclusive breastfeeding at 6 months is 22%. And so I think that improving community support is going to be one of the critical components to improving breastfeeding duration in this country. And so that's something I think that I would encourage you to take a critical look at and see, if there are areas where improvements can be made on Step 10. All right, staff training is next. We saw an improvement of 13 points from 51 in 2007 to 64 in 2015. This is an area where most people can improve. And so it seems to be a real challenge area with most states scoring less than 70. The 2015 national average was 64%, with state scores ranging from 35 to 91%. So although this Tennessee breastfeeding toolkit is not specific to staff training, I wanted to use this resource to highlight the staff training domain. You can see the web address at the lower left-hand corner, and it really is a great extensive resource for all the care domains. So they've created the left-hand page is the main page, and then for each of the care domains, you can see they've created a sub-page which links to a variety of resources from around the web, which can be used to improve that subdomain. And so, and it also has a link to the CDC mPINC website you can see with the big M. So I encourage you to look at this resource, and also if there's, especially if there's specific areas where you'd like to focus, you might find additional resources, in this toolkit that will help you address those. Okay, the final domain is the structure and organizational aspects of care delivery, which has also seen improvement from 66 in 2007 to 77 in 2015, which is an increase of 11 points. Again, this is an area where many hospitals are still finding challenges, and that a majority of the states have scored at 70 or below. So to highlight this a success story from the structure domain, I want to take a closer look at the brochure called Right from the Start, How Texas Hospitals Can Reduce Obesity Through Breastfeeding Policies. It was produced by the Texas 10-Step program of the Texas Department of State Health Services. So this report discusses the importance of breastfeeding, and in particular exclusive breastfeeding, and points out that Texas hospitals have a lot of room to improve their breastfeeding rates. It then goes into highlighting how policy drives practice, and I think that this is so critical. And so they have this figure in here, which shows the Texas mPINC scores and compares it to the national average as well as to the states that are scoring the highest average. So Texas, in part because of this document, but also the other efforts that they're making within the state has improved their structure and organizational aspects of care sub-score from 59 in 2007 to 71 in 2015. And this increase, the reason I highlighted the policy part is that they increased the proportion of hospitals that contained a model breastfeeding policy from 7% to 32%. So I think that's a huge success, and to be able to improve that much. And so now I want to talk a little bit about the 2015 data availability. Many of you are aware of this, but I like to reiterate it just so people know. So again, we send a hospital-specific benchmark report. We send 6 copies to the hospitals, and including to the administrator, the director of OB, the director of pediatrics, director of quality improvement, as well as the mother-baby nurse manager, and then to the person that received the survey originally. Our website, our email address is on right here in the middle, and so questions related to the mPINC survey can be sent to that email address, and somebody will respond to them. We publish our state-specific reports. We email these to the state at the state level, but we also put them on our website. And then we also put our national aggregate web tables on the website. And there's actually quite a bit of information there. We have all the years from 2007 to 2015, and we have the data broken down both by certain demographic characteristics such as facility size, level of care, whether you're a teaching hospital or not, but then we also put the state data on that page as well. So I encourage you to look at those resources if you haven't. So in conclusion, I think that what many of you see is that hospital practices are improving. The total mPINC score as well as the sub-scores are increasing. But there are definitely areas for improvement where we continue to make improvements, including staff training, as well as structural and organizational aspects of care. I don't know if people have heard, but we are in the process of completely revising the questionnaire. There's been a lot of changes in maternity care practices over the past 10 years, a lot of improvements like we've just talked about, but also just changes in practices. And so we've taken into account, a lot of those changes. And so the new survey will be web only. There will no longer be an option to fill out a survey on the paper form and send it in. The hospitals will have the option to print off a survey to use it as a data collection tool, but then the actual survey will have to be entered online. And so with these changes, we have set a target launch date for 2018. So there are a lot of administrative processes that we have to go through here in order to get the survey launched and so forth. So some of the actual time frame of when it will be launched it depends on that. But again, we typically announce the survey's launch on the weekly Wednesday Wire. And then we'll have other announcements, to make sure that people know that it's coming. So as I conclude, my charge to you is really in the new year, identify, 1 to 2 areas that you think, where you could change, where your state could change, where you can work with the hospitals in your state to change, and hospitals that you work with, identify areas where, for improvement, but really just focus on a few, 1 or 2 areas. Develop or bring people together, form a team and brainstorm on why that's a problem area and how that problem might be solved. And then I encourage you to use some of the resources, the Bardic article, the Tennessee website, and because those resources outline ways that these problems have been solved. Many people are probably facing the same problems and might have found unique solutions that you might be able to implement, or the hospitals might be able to implement. Think creatively, think of out of the box solutions. And then once you've tackled that 1 or 2, the first 1 or 2 goals that you've set, go ahead and head on to the next one. So, and again, before I launch the video, these findings and conclusions are all mine. That's the little disclaimer at the bottom. They don't necessarily reflect the official position of CDC. But I have my email address here, and then this video, before we show it, I don't know, many people might have already seen it, but we put together a whiteboard animation, and this is really targeted towards, hospitals, hospital administrators, movers and shakers, and it really is just a 4-minute video that talks about mPINC and why it's important and how, how we can make change. And so I encourage you to show it. It's on YouTube, and I think that it's a really powerful tool to help people understand mPINC better. So I'm going to turn it over to Kenny to show the video, and then we'll open it up for questions.
Thank you, Jen.
How well does your hospital provide the maternity care that mothers want and babies need? According to Dr. Tom Frieden, Director of the Centers for Disease Control and Prevention, hospital practices are a critical factor for successful breastfeeding and infant nutrition.
It's important for all infants to get a healthy start in life. For nearly all infants, breastfeeding is the best source of nutrition. It provides remarkable health benefits to mothers as well. Even though 80% of U.S. mothers begin breastfeeding their infants, many don't continue as long as they would like to, and only 1 in 5 continues exclusive breastfeeding for their recommended minimum of 6 months. Hospital practices in the first hours and days after birth make a big difference in whether and how long a mother breastfeeds her baby. I urge each of you to promote and support breastfeeding for every new mother who is able to.
Use your CDC Maternity Practices and Infant Nutrition and Care benchmark report to improve breastfeeding support for mothers and babies in your care. The mPINC quality improvement process started in the early 2000s when CDC met with a panel of experts and hospital administrators. They recommended that improvements in maternity care practices be assessed and monitored over time in all U.S. birth hospitals. CDC administered the first mPINC survey in 2007 and has continued the survey about every 2 years since. We analyzed the data and produced individual facility mPINC benchmark reports to provide points of reference for evaluating change in performance in maternity care practices that support breastfeeding. The reports are free to participating U.S. birth hospitals. They're organized to help you understand how your hospital performs across 7 domains of maternity care that support breastfeeding. This reflects care that begins prenatally and continues through hospital discharge. It provides a logical framework for integrating evidence-based maternity care practices that support breastfeeding in hospital policies and daily routines. Each domain is scored and averaged to provide a total score. You'll see how well your birth hospital compares to other birth hospitals in the U.S., in your state, and to those of similar size. In addition to improving birth hospital performance, mPINC benchmark reports have driven nationwide improvements in maternity care. Some birth hospitals use the mPINC process to move towards achieving the baby-friendly designation, a distinguished standard of excellence in maternity care that supports breastfeeding. Over 80% of U.S. birth hospitals participate in mPINC. Be an mPINC champion. Bring together your maternity care team to review your mPINC benchmark report. Include obstetricians, anesthesiologists, pediatricians, maternity care staff, nurse managers for mother-baby care, administrative leaders, quality improvement officers, lactation specialists, and others. Identify and take action on priority areas to improve your birth hospital's performance. If you want to go fast, go alone. If you want to go far, go together.
Wonderful. Thank you so much, Jennifer, for that terrific session. Just so timely, and as Dr. Nelson said, our New Year's resolution is really to translate data into action. There's just so many options for us to be in so many ways that we can make a difference in our cities and in our state. So I am going to So we have a cluster of questions, Jennifer, some of them around how can coalitions play a helper role, and most of our coalitions are multi-sectoral in the sense they do have mostly public health and healthcare, but as the video shows that, what are some ways in which bringing stakeholders together might be ways in which coalitions, what could coalitions be doing to play a greater helper role in distributing these data?
So that's a great great question. You know, I think that if you have the capacity to hold a meeting to bring in key stakeholders, such as, you know, individuals from different hospitals, I think that's a great way to get people in the same room and talking about, you know, the issues at hand. And in that context, you know, you could talk about your state data and so forth in areas in comparison to you know, the states in your region, the states around you, but as well as the you know, compared to the national data. And then too, I mean, disseminate the information. I'm sure that each of the, well, I don't know, you know, if the state coalition has a listserv of people, you can send out your state reports to that listserv and you know, make sure that they're aware of our website and other resources available to them. And so, you know, I think that, and then third, if you know that there are facilities that are, you know, trying to obtain the baby-friendly designation or trying to make those improvements, you know, identify ways that you can provide technical assistance to those specific facilities versus a facility that might not be that further along in the process. So that's how what I would think about.
Thank you. That's really kind of key. And what you said about, you know, it's initiation, duration, and exclusivity. Since we are, you know, working on that, the hospital maternity care practices is what gives babies the, you know, the first start, and then coalitions could play a very key role in that community support critical component of that too for step 10 and making sure there's that continuity of care. And I just want to, I hope I have my stats right, but we've talked about the mPINC survey today, but the impact of what CDC has done in these last years and the impact of the investments that you've made in getting the maternity care practices moving, supporting hospitals and state hospitals in various states to go baby friendly has been phenomenal. And so the percentage of U.S. hospitals implementing a majority of the 10 steps has increased from 29% in 2007 to 44% in 2011 to 62%. So a big part of that was also the Best Fed Beginnings project that CDC funded in, you know, with in multiple states with more than 80, almost 90 hospitals. And right now there is the Empower Breastfeeding project that's also happening in the southern states, right, Jennifer? And it's just so many states right now across the nation. I think there are some questions about how about Empower specifically. Is this something that you can address a little bit about the project, Empower project, and how the maternity care practices are being accelerated in these states?
Yeah, so there are there are 93 hospitals in the Empower project, and so that's a cooperative agreement out of it's being run by APT Associates, but it's also in collaboration with CDC, with Carolina Breastfeeding Institute, and a few others. And so, and it's very similar to Best Fed Beginnings in that, you know, we're trying to increase the number of hospitals that are baby, you know, have achieved the baby-friendly designation, but then also to really identify the best practices on how to do that. And so this is the third and final year of funding. I believe there are 3 or 4 that have already received the baby-friendly designation. And so, you know, with the Best Fed Beginnings project, over 80% of the hospitals actually eventually received the designation, and so that was a very successful project. We hope for the same success with the Empower project. The hospitals are very engaged, and they have fewer hospitals have dropped out than and so that's great.
Thank you, Jennifer. And I know that you addressed this. This question is, if a maternity care hospital has not received a survey in the past, how do we ensure that they get a survey in the coming year?
Yeah, so many, a lot of the questions that come into the mPINC box are, we haven't received a survey, or this is the person that, the survey should go to, and so forth. And we actually don't keep a record of, the people who the survey should go to. And part of that is, there's kind of twofold reasons. The main reason is we want to ensure we have a standard protocol for contacting facilities that, for each facility. So each facility has the ability to either be in the survey or not. And so that, and as I mentioned in the talk, the protocol is to call the hospital switchboard, asking for the mother-baby manager, and then once that person's on the phone, asking that person who's the most appropriate person to receive the survey. And then, the other reason too is that there's a lot of change within the hospital, and so it would be a very big challenge to keep an updated list of people, hospital contacts. And so, if hopefully, I don't know if the question came about a specific hospital, but using the methods that we have to identify the universe of hospitals, we're hopefully capturing all of the hospitals that are providing maternity care. As you can imagine, that's also a huge challenge, in that there are constantly hospitals either closing the maternity unit, merging, there's a new satellite facility. So trying to maintain an accurate list is, it takes quite a bit of effort. And so I encourage you, if there's a hospital that you know is doing maternity care but has not received a survey, please email that the mPINC box, the mPINC@cdc.gov, and we'll look into it and so forth. For some of the hospitals in the survey, some people will email and say, I didn't receive a survey. Why didn't we receive a survey? And or where it more likely to be, where are the hospital results? And it's sometimes we'll send a survey to a hospital, and then they actually won't complete it or won't fill it in, and so then that hospital obviously would not be included in the survey. But again, we aim to capture every single hospital, and so if you know that there's a facility that might not be in the survey, then we need to look into that.
Great, thank you. And that's where coalitions can play a very critical role, not just state, but the local level coalitions, because when you know, and you will know from CDC and from USBC and from your other sources, that now the surveys are just, make sure that you're connecting with your local hospitals, birthing facilities, urging them to participate in the surveys. So that's where coalitions can also be very good connectors. So one other question is, with the mPINC collection being revised and future data collection being submitted electronically, do you expect these reports to continue to be every other year, or do you, as someone is hopeful here, that they might be available more frequently?
That's an interesting question. I definitely don't think that they'll be available more frequently. There's actually quite a bit of work that goes on in the behind the scenes to get the survey ready, to to get the approvals to administer the survey, and then once the data are processed, to actually analyze the data and produce the reports and so forth. I think that as we move forward in the future, we're going to hopefully try to streamline some of that work, but I doubt that the survey will be every year.
Thank you. Yes, and we wanted to also, I also wanted to let you know that the USBC is supporting one of the constellations is maternity care practices, and this constellation is stewarded by the Carolina Global Breastfeeding Institute. And this constellation has some priority strategies, and for soon we will be having a community of practice where state coalitions and other entities could be part of that. And we are hoping that a lot of these uh, currently funded projects that are happening, there's so much best practices and good evidence-informed learning that's happening, that we could be able to share some of that's already happening in the field through many of our partners. The CDC Breastfeeding Work Group has webinars. The other grantees like ASTO and AmChip have webinars as well. So, and some of the non-CDC funded CHAMPS also has, and many of these are accessible to everyone. So we hope that we'll be able to curate and get a lot of these resources for everyone. We keep sharing these links for any announcements that come up in our learning community. So we hope you'll join those. I think there were some questions about, some of the state programs that folks are giving a shout out to. Definitely the Texas 10 Steps, the Vermont Birth and Beyond Project, things that are happening in California, but the Birth and Beyond Project as well. And like you mentioned, Jennifer, that California has been very creative in using some of these facility data. So this was an extra kind of a arrangement with CDC to get that kind of regional, that they've been able to actually get these facility data and do more, form regional cohorts and things that need targeted resources to improve their mPINC facility scores. So would you be able to say a little bit about how they get all this extra data?
Sure, of course. So being being the federal government, the data are actually belong to the public, and so any state is able to request their state-specific mPINC data. So in many states have, and so we there's a data use agreement that we ask the states to complete, and then and just asking what the intent of the use of the data are, and so, but then we are able to send the data to the state health department. So, and then researchers are also available to request the data. We can't provide hospital-specific information to non-state health departments, but the aggregate data, the de-identified aggregate, or the de-identified data we can. So, people can get access to the CDC data, again, if you're, to look at specific questions and so forth. And the mPINC mailbox, the address mpinc@cdc.gov. If you're interested in that, you can send an email to that address, and then we'll get you the necessary forms.
Thank you. And is there, and I think you clarified that it's only state level that can get the list of hospitals, facilities that have participated in mPINC, right? If they email you, would a state coalition member or a breastfeeding advocate be able to just get the list of hospitals that have participated in mPINC? No.
No. So the hospital identifying information is only available to the state, which is it would have the ID as well as the name and address.
Right. Thank you. And for those of you who have already sent us stories, we have a story collection right now, and that talks about how the CDC maternity care quality improvement programs has made a difference, either from a provider point of view, if you're a hospital staff or a public health staff, but also from a patient point of view. So Danae is going to send, has chatted a link for you. We want to keep those stories stories coming, because this has been there's a long way to go, but what a difference these last few years have made, and measuring it has given such specific guidance at the local level to facilities and hospitals as well. So it's wonderful. I also wanted to let you know that there are state-specific fact sheets that you can use with your own state mPINC scores. They are available on the USBC website. We hope you will use those, your state-specific mPINC scores. Feel free to customize those state fact sheets any which way you want, and use it to educate stakeholders in your communities and in your state. So with that brings us to the end of today's session. And thank you again, Dr. Nelson, for such a terrific and timely presentation.
Thank you for having me. I really appreciate it.
Great. And thanks to you all for all that you do for moms and babies and to improve health outcomes and make our communities healthier. So until next time, goodbye.